welcome everybody to March's IIDR joint rounds. I'm Laurie Burrows. I'm the acting director of the IIDR. And it's my great pleasure today to introduce today's speakers, Dr. Marek Smieja and Dr. Don Bowdish. Dr. Smieja is a microbiologist, infectious disease physician, and the interim chief of the Hamilton Regional Lab Medicine Program at Hamilton Health Sciences. His primary research interests are in the diagnosis of respiratory and gastrointestinal infections, and in the role of chronic infections in respiratory and cardiovascular disease. He is involved in the development and evaluation of diagnostic tests for SARS, coronavirus, influenza, and rhinovirus. And today he's going to be discussing clinical lab testing, as well as surveillance and outbreaks in the homeless and the Pearson International Traveler Study. Our second speaker, Dr. Bowdish, is a professor of pathology and molecular medicine and a Canada Research Chair in Aging and Immunity. Her lab studies how age-associated inflammation alters monocyte and macrophage development and function, and how this ultimately increases susceptibility to pneumonia. And today she's going to be discussing saliva testing in asymptomatic and pre-symptomatic SARS-CoV-2 infections. So thank you both for joining us today. And Dr. Smieja, I'll let you take it away.
Thanks so much, Laurie. This marvelous title was come up with by Don, Spitting and Sniffing to detect COVID-19. We debated whether it should be sniffing or sniffling, because my focus really is on the nose, whereas Don's is on the saliva. And while we'll be very, very polite, you actually must recognize that there's this huge rift between these two diagnostic camps as whether the nose or the saliva is a better place to sample. Although you'll see that as the ultimate compromise, we end up doing a little bit of both. So thank you for this opportunity. It's always a pleasure to present to this group and to present with Don. So my three objectives for the first half hour or so are to describe clinical laboratory testing in Hamilton, which we've been doing since last March, to describe the ongoing study of homeless shelter surveillance, and then to describe the completed study we did last fall of international travelers at Pearson. So I'll start with clinical laboratory testing. And for many, many years, the standard has been to obtain a nasopharyngeal swab, sometimes a nasopharyngeal aspirate, although that tends to cause more risk to the collector. And so nasopharyngeal swabs have been standard for probably 30 years or so in Hamilton, and really have been optimized over the years to collect really well. We've also accepted nasal swabs in the past, throats, even throat gargles. I can remember training 25 years ago where we would have a person gargle with a culture medium for viruses, and then we'd see if that could actually grow any of those viruses. Not a really safe thing to do anymore. And finally, if a person's really ill in our intensive care unit, the best sampling may be bronchoalveolar lavage. And back in SARS of 2003, that was actually the best clinical specimen, whereas post-mortem, the best specimen was actually to biopsy the lung. So we know the original SARS coronavirus, now called coronavirus type 1, was in intense pneumonitis. It caused intense inflammation of the lungs. And we believe that in severe cases, that's exactly what SARS-2 does as well. And then in terms of what you can detect antigen, and there are point of care tests and rapid tests for antigen. You can culture this, but you don't want to culture these except if you have a level 3 laboratory because of the biosafety issues. You can do serology or antibodies, but that always lags by 1 to 3 weeks. You can do PCR, either uniplex PCR for a single target or multiplex PCR. So our standard has been nasopharyngeal swab. It's what we call a flocked swab, and that'll be important in a moment, and then the multiplex PCR that we do for this. So testing began because I went away on holiday. I took a short holiday in January of 2020, and while I was away, the incredible Dr. David Buehler and Sylvia Chong, who have worked on diagnostics for many years, looked at the first published whole genome of SARS coronavirus type 2, designed 4 separate primers and probes, wrote for my permission, but since I was on holiday and ignoring emails for 5 glorious days, they went ahead and ordered primers. And so when I came back and said, oh, absolutely, absolutely order these things, they had already done that. And so by the end of January, we already had primers and probes, some of which others had described, like the envelope gene described by Corman. But some of these, like the 5' UTR, are unique. These were designed here in Hamilton by David and Sylvia, and these are still used clinically by us and by several other hospitals across Ontario. And then Candy Rutherford, who is our technical specialist at HRLMP, adapted the 5' UTR to a multiplex she already had for 9 other respiratory viruses. We ended up dropping the lowly parainfluenza type 2, and we ended up changing one of the controls, and then we were able to do 5' UTR. And we still run that assay, although that's a small number that we run compared to our main pathway. We extensively tested these in late February into early March. And then if you remember, WHO declared a pandemic almost exactly a year ago on March the 11th, 2020. And we started routine clinical testing in our clinical laboratory March 16th, 2020. We had already identified a couple of people at that point in the community who weren't suspected COVID, who hadn't traveled. And even though we were still validating the assay, we shared that information with the attending physician and with the public health department, knowing that these are almost certainly going to be COVID, which they were, and to be able to hopefully isolate people and prevent outbreaks. And we wonder, we'll never know for sure, but we wonder if this intense testing back when there was still very little COVID in Hamilton perhaps contributed in some positive way to slowing down the outbreaks in Hamilton. And Hamilton, even though we've had a relative amount, we've actually had quite a few fewer cases per capita than places like Toronto and Peel. So we've run 2 main assays, the respiratory multiplex together with flu and paraflu and RSV, et cetera, and then the COVID-only triplex, which we started around April of last year. And this one includes this 5' UTR, an envelope gene, and then we also have RNase P, which measures human cells as an adequacy marker. The extraction methodology changed. We had the BD Max, which comes with its own extraction kit. And then for our main pathway for the triplex, we were using bioMérieux EasyMeg. And as you'll learn in a moment, everything we used ran out at some point. The whole world was trying to do the same thing, and all of these reagents ran out at some point. So we had to very quickly pivot to a Promega extraction methodology, which we still use, initially on an Eppendorf liquid handling robot, which started in April last year. And then we changed that over to a Hamilton Robotics MicroStar, and then very recently obtained Advantage. And these are now our main workhorses since the fall. We've used various thermocyclers. The BD Max has its own thermocycler, so it's kind of a extraction plus amplification in one unit. And then we've used QIAGEN rotor genes, and more recently the Biorad CFXs, and those are our main workhorse at this point. We've accepted various specimens. We've always accepted nasopharyngeal swabs. In fact, those have always been preferred. And then since the fall, we've preferred them made in a locally invented medium called McMaster molecular medium, which both stabilizes and inactivates. So it actually dramatically simplifies the workflow. We've also validated and accepted deep nasals, throat swabs, sputum, and bronchoalveolar lavage. We've never accepted other specimens like saliva or stool or blood, although in research we can show that those are often positive. Saliva we'll hear about from Dawn. We've done a little bit of work on that, but not a lot. We've occasionally looked at blood for very ill ICU patients, and the very sickest patients may actually have viremia, may actually have virus you can detect in blood. And finally, we've got an ongoing study of looking for it in stool, and we can find it in some people, but probably up to 40–50% of people who have COVID will have it in stools, and it may actually be detectable there longer. So rather than telling you how we do things, I'll tell you all the crises we had, because this really illustrates the whole diagnostic pathway. So first of all, you need a nasopharyngeal swab. The gold standard flocked swab that I was talking about are made by Copan Italia in northern Italy, which, if you remember, was very, very heavily hit last January by COVID. And so we ran out of those. The whole world ran out of these. And so nasopharyngeal swabs, when they ran out, we had to temporarily substitute an ordinary swab for throat and nasal. But then on, we and then the Ministry of Health were able to import large amounts of these from basically knockoffs in China, which then had to be sterilized to ensure that there was no safety issues. And those continue to be used in Ontario. So our primarily suppliers are from various companies in China. Next, the transport medium ran out. And also our transport medium was made by Copan. That was the gold standard. It was called UTM for Universal Transport Medium. And almost all FDA submissions of respiratory viruses, including COVID, are made with UTM. And then the province basically sourced these from all over the world, and we had 20 different media, none of which had very good long-term quality for them, many of which were really just some sort of buffered saline or maybe a few other things added in. And then David Buehler in our research lab developed, and he's developed many of the methodologies you see here, but he invented something called McMaster molecular medium. And he started this back in April to support the shelter health studies you'll hear about. And then this has become a standard for many laboratories across Ontario. It inactivates and it basically simplifies the whole extraction process. It stabilizes so that it can be stable at room temperature for 4 months. And while today we process things within 12 to 24 hours in our clinical lab, there was a time we got behind and it could take 3 to 5 days. And we worried about the integrity of the virus sitting in as transport medium for over 3 days. We had the BD Max methodology. We liked this. We thought we would do up to 1,000 a day. But then the company, because the whole world was trying to get these kits, limited us to 400 a day. We're getting slightly more today, but until very recently, we were limited to about 400 runs a day. So that was a major limitation. We developed extraction methodology based on the bioMérieux EasyMag, and then the whole world ran out of this because, of course, the whole world was doing PCR. So we substituted another methodology called ProMega, and then David, in his spare time, actually developed something very similar to EasyMag, which works incredibly well, but today with fewer shortages, this is at this point has not gone into sort of regular commercial production. We had all sorts of equipment delays. We ordered 2 more BD Maxes. One we ended up canceling. One took about 2 months to get here. We ordered Hamilton Stars. They took about 4 months to get here. We ordered Advantage, and that's recently come in. And then all the tips you used, all the deep well plates, all the plastics, all of these ran out at various times, and they dramatically affected our capacity to be able to do as many as we wanted to, or at least we had to pivot temporarily to other methodologies, as well as delaying, beg, borrowing, and stealing. And David's actually sat down with the same engineers that he sat down for some of the other things to design some of the plastics so that if we need to, we can locally produce at least the deep well plates. And then, of course, we had staff shortages. You can't get enough MLAs, MLTs. You can't keep them here working 24/7. So we've had a prolonged hiring binge over about 6 months, and we're constantly hiring more people because it's both expansion as well as some people get tired and go on to work in other labs. And then finally, we ran out of space for all these robotics. So we're actually rebuilding office space to do all this. So you can see this has been a crisis-laden, incredibly intense year. And despite that, we've been able to do a huge amount of testing in our clinical lab. So in the last 1 year, we have performed almost 500,000 tests. We're performing about 13 to 18,000 per week. The red line is the total number of tests we've performed. So you can see it peaked at about 17,000 in a week. The blue indicate the proportion positive for SARS-CoV-2. So next I'll describe our homeless shelter study. And this has really been the passion of the whole research lab and really a marvelous partnership with the doctors and nurses and others who run the homeless shelter health program. And this is part of something called Shelter Health. This network has existed in Hamilton since 2005. And I've had the privilege of first helping train and then working closely with Tim O'Shea over many years on studies like this. So Tim O'Shea is he's a medical director for the Shelter Health study, for the Shelter Health itself. He knows and goes to a lot of these shelters on a regular basis for medical care. And so he basically identified very early that we had a very vulnerable population and a setting in which outbreaks could occur very quickly. So the first thing Tim did is he worked with our clinical lab to be able to rapidly test any symptomatic patients while they were put in isolation. He developed a number of isolation beds so that anyone with symptoms was put in isolation, tested generally within 12 to 24 hours, we would have an answer, and then they could either continue isolation or they could come out of isolation. And this would work as long as the numbers were relatively small, because for the whole city, we had about 7 isolation beds at this point. By April, there was more angst. There were a lot of outbreaks in Toronto and elsewhere. There were a lot of international outbreaks written up. So a lot of angst about the shelters. And so Tim worked with our research laboratory, and particularly with the David Buehler and Jody Gilchrist. And we've developed what we call a weekly surveillance study of 8 shelters. And we developed it as a true cluster randomized trial where 2 shelters got passive surveillance only. So no ongoing surveillance. They were tested if there were symptoms. 2 had nurse-collected nasopharyngeal swabs every week as kind of the gold standard. 2 had self-collected oral swabs, and 2 had self-collected oral nasal swabs. And basically, we've kept this study up for almost a year now. It started last April, so next month we'll be into a full year. And you'll see on the left-hand side that there were, at the beginning, places where we did nasopharyngeal swabs. In fact, we did those for 4 weeks, and then everyone ran away and said, we do not ever want to have a nasopharyngeal swab again. So we had to convert those shelters over to our oral nasal methodology. And so the main comparator throughout this study has been the oral nasal, which is in the red, and the, oral nasal, which is in the green, and the oral only swab, which is in the red. And these are our cases. We met many, many months with only an occasional case. We were really, really very happy. The staff were very happy. One of the things that we know we provided very early on is assurance that it was a safe workplace, because one of the worries back in March was the workers were scared to go to work. They didn't want to work in a setting where outbreaks were likely to happen. And then you can see through the fall and now into January and February, we've been having more outbreaks. And in fact, we've had outbreaks now of up to 30 people. Those have been written up in the spec, but aren't on this graph. This graph goes to about early January, when we actually stopped the randomized trial component. And during that randomized trial component to about mid-January, we saw a total of 20 COVID cases. 15 of those were detected in the oral nasal arm, and 5 were detected in the oral swab arm. None in the NPS, because that only went on for those first 4 weeks. Small number of people, and then as mentioned, we abandoned that arm. So overall, what did we see? From April to August, we had public health help to actually visit the shelters to supervise the self-collection. And then they were pulled to do contact tracing. So then the research lab directly got involved. And particularly Jody, Nicole, Val, sometimes others got involved, where every day they would go to 2 shelters. They would sit there for hours on end while people came, self-collected, register people, get those to our research lab. And we collected over 10,000 specimens and from over 1,500 staff and residents. And some of the regulars, about 50% of people gave 20 or more swabs. So there were some who only gave a couple of swabs. Some only gave swabs when there was actually some worry that there already was COVID in their residence. And in fact, in January and February, we've been able to have a number of new sites join us. So from January to present, we've actually converted from a randomized trial to a simple cohort. Everyone gets the same thing. And this was really done because we were concerned about not doing surveillance in 2 of the shelters. We were concerned about not doing what we felt was the best swab at this point, which is a combination of the same swab inserted first orally, both sides swabbed, and then nasally. And this is self-collected, but it really samples both a bit of saliva as well as nasal secretions and nasal cells. And we now have over 20 participating shelters. And in fact, every day we get more and more specimens. The one thing we've done is where there have been small outbreaks, we've tried to increase the frequency of swabbing so that we can identify and try to decrease the total size of an outbreak. And this seemed to be relatively effective until the last outbreak, where we had a large outbreak that basically did cause a lot of cases. So. And then during one of these recent outbreaks, we were able to go back to a number of the positive residents and compare directly an oral swab, a nasal swab, and the oral nasal methodology. And so the oral swab, so first to orient you, 40 represents no virus. 40 is the CT value from the multiplex PCR. This is for envelope gene, just as one example. And so where you see them coming up to the very top, we actually didn't detect any virus, or if it came up close to the top, very little. So the lower down you are, the stronger the viral load is here. And so you can see for every triplet of oral, nasal, and nasal, the oral was always the worst. The oral nasal was either the best or very, very close to the best. And the nasal was somewhere in between, but generally paralleled the nasal. So arguing strongly that the main source of virus, at least when we sample virus by taking a small aliquot of saliva, we estimate that a swab can absorb about 150 microliters of saliva. In all of these, we can see that the nasal, and this was appreciably stronger. So if you take, for example, person number 9, you've got no detectable in oral. You've got a CT of about 25, which is quite strong in both the nasal and the oral nasal. So the key lessons were, first of all, nasopharyngeal swabs, even though we still use them as our gold standard in the clinical system, were not tolerated well, and everyone abandoned them within 4 weeks. Weekly oral or oral nasal were well tolerated, and have been sustainable for almost a year. We do feel, though, that even though we haven't done all the cluster statistics, we've definitely felt uncomfortable continuing with the oral swabs or with no swabs. So we feel we have demonstrated superiority of the oral nasal combination. We've had, until recently, very few outbreaks in a very limited size. So we felt that we had been quite successful until recently, unfortunately we're starting to have some larger outbreaks. We demonstrated the feasibility of large-scale collection because these are people collecting their own. It's not staff collected, with very few exceptions. And we believe this is probably the largest and the longest running homeless shelter study in Canada. So tremendous effort led by Tim O'Shea. And the third objective I have is to briefly describe our study of international travelers. And this was led by Vivek Goel from Toronto and by myself, David, Dominic Mertz from McMaster as well, Lorella Rosello, and Cheryl Regeher. So a nice collaborative effort, huge team of people. This took about 100 people to mobilize. We had 6 people working at a time to screen travelers as they came through. We had a whole cohort at the lab end, although the actual running of this at the lab end, because David had developed such a nice, efficient robotic methodology, is we ran about 1,000 specimens a day with 1.5 FTE. So incredibly efficient. So in the first pilot phase, the study was really meant to be a pilot to inform Air Canada and Health Canada and others about how to do longer term surveillance, which they now do. We wanted to establish a study to, first of all, ask, can we consent people in the aircraft or in the terminal? And about 10% of people were actually consented in the air and filled out their questionnaires and so on. And then we had registration and a testing booth in the terminal after you come through baggage claims, but before you exit into the main public area. We wanted to determine the acceptability. We wanted to determine the quality, and we were doing all this through self-collected swabs, but the first would have been staff supervised, and then the last 2, the 7 and 14-day one, were done at home. And the basic idea was we wanted to know at landing on day 7 and day 14 whether travelers were shedding COVID as a marker of whether or not quarantine was important to prevent people who were incubating COVID. So we wanted to assess how many people arriving had COVID. We wanted to assess how many who were negative at baseline tested positive at day 7 or day 14. And a priori, we believed we would detect virtually all people by day 7. We wanted to assess their health and well-being. We wanted to get some questionnaires on attitudes and beliefs. And we wanted to ask what lessons here would allow scale up of such surveillance programs in future. I won't go through all of the details because I think I've already stated, but the basic bottom line is they had to live in the Toronto area. We had to be able to access them. They had to speak English or French. And then we had couriers dispatched to pick up their day 7 and day 14. All PCRs were performed by Research St. Joe's. And then we used an oral swab, which is basically the same swab we use in our shelter health. Of the 2 swabs you see illustrated, the one on the left is a nasopharyngeal swab. The one on the right is actually, that particular one doesn't show it, but it's actually a slightly thicker and longer fiber than the nasopharyngeal. Nasopharyngeal is meant to be very thin because it's very uncomfortable otherwise. And so basically we collected oral then nasal, and not we, it was the people themselves. The oral collection was simply you inserted this between your gums and your cheek, you turned it 3 times, you repeated on the other side, and then the same swab was inserted into the nose, parallel to the floor. Very importantly, a lot of nasal collection is done by going up. But it shouldn't, that's what we call the anterior nasal. That's not ideal for cell collection. So these are meant to be parallel to the floor, inserted 2 to 4 centimeters to comfort, turn 3 times, repeat on the other side. And then these were put in the McMaster molecular medium. This is a guanine isothiocyanate-based medium, which inactivates lysis virus. It's biosafe, and it stabilizes RNA so that there's no deterioration in transport. All of these were barcoded, and then the whole system allowed the laboratory to result these based on that barcode. And then we were able to alert people to their results, usually within 12 to 24 hours. And they would get a text or an email stating you have results available. They'd log in and see their results. We had a total of 17,744 people who said they were interested, of whom 16,361 were actually signed up, did the swab, and are kind of our intake cohort. And then you'll see we lost some of those by day 7 and a few more by day 14. So the day 14s represented about 11,600 out of these 16,000 people. We estimate about 85,000 people came through Terminal 1 during that time, and probably about half of them would have been eligible for our study based on some of those inclusion-exclusion criteria. This all happened between September 3rd and about October 31st. We got quite a range of ages, genders, continents, etc., but we got very few elderly people. Only 15 people were 80 years and older, partly because such people travel less, but also some of them may not have had English or French as a language they were comfortable with, or weren't comfortable with some of the computer-based consenting and questionnaires. Half men and women. You can see most came from the Americas, especially from the United States, but we had a reasonable number from Asia and Europe, a small number from Africa. And then we classified the countries at the time that people came into Canada by green, orange, red, based on a European classification system of prevalence of disease in those countries and positivity rates in testing. And then we also had a gray zone where we didn't know. And we had all those were represented, but the green was underrepresented, only about 5%. And then we asked questions like, have you had COVID? Have you had COVID in the household? Have you had symptoms? And a small number had. We also asked them, if you had to be tested for travel, and almost everyone said, yes, that would be fine. Only about 4% said it would be unacceptable or very unacceptable if a test was required. And as you know, that is now the standard, has been the standard in many countries for quite a long time before Canada started. We also, though, asked them if vaccine would be acceptable. And many of us are obviously interested in vaccination. And I wonder whether universal vaccination will be required for travel at some point. But in fact, almost 20% of people, and these are travelers consenting to be part of our study, almost 20% said it would be unacceptable or very unacceptable if they had to have a vaccine in order to travel. So interesting conundrum, because a nice public health solution down the road when we control COVID better in most advanced nations will probably be to make sure everyone in the world, including all nations, has access to and can get COVID vaccination. But secondly, we're going to have to control our borders at some point, and the logical way would be through vaccination, but it's not clear that'll be acceptable to the entire public. The overall positivity was almost 250 people that we identified, 248, of whom 167 were identified on arrival. So these people are coming in with either acute or relatively recent COVID. By day 7, we have an additional 67 people, and on day 14, we identified another 14. That's 14 out of 11,000, so a rate of just slightly more than 1 in 1,000. And of those people, virtually nobody had symptoms on baseline, but about half of the people who were positive developed symptoms subsequently. And so in the first column, the ones who were identified at baseline, not everyone told us. So you can see about half the people didn't answer this part of the questionnaire. But of the ones who did, Very few positive on landing, even though they're positive, but 40% by a week and still about a quarter at day 14. Whereas those who were only identified on day 7, a higher proportion, 30 to 40%, told us they had symptoms at some point. And then of those at day 14, they had no symptoms all along, but of the ones who told us, 3 out of 8 did tell us they were symptomatic, either at that time or subsequently. And then if you look at the rates by week, at the bottom are the oldest ones at the beginning of September. Generally, you can see that in September, we had fewer cases than in October, roughly 1% in September, roughly 2% in October. Had we continued the study, I'm sure by December, this would have been closer to 3 or 4%. And then by age, slight increase in younger people, but not a huge. All ages were well represented. Somewhat more in men than in women, but again, quite high in both. And then importantly, country of origin, the gray countries being ones where there was insufficient testing to know what their true rates were. These were the highest. And then red, orange, and green, while there was a nice gradient, we had hoped that green countries would be so low that you could say green countries don't need a lot of quarantine or testing, and that was not true. Even from green countries, we had a rate of about 1,000 per 100,000. And these are the countries that were mainly represented. Green was countries like Germany, Nigeria, Poland, Serbia. Germany by October had converted to an orange country. And in fact, countries like Poland and Germany have had quite a few cases since that time. Gray countries you can see on the right, but importantly included the Caribbean. Relatively little data at that time about the Caribbean. And it was only recently that there's been a great restriction in travel to those countries. We also looked at viral loads, and viral loads here using the cycling threshold. The ones on the left-hand side below 25 are almost certainly acute disease. These represent probably replicating virus that started up in the last 1 week. The middle ones between 25 and 35 may represent acute, but they also may represent some people where their disease was 7, 10, 14, maybe even later. And then those over 35 almost certainly represent old disease. They could represent very, very early disease, but they most likely in asymptomatic people represent disease that occurred weeks ago and ideally should not be banned from travel because they almost certainly represent no risk to anybody. And this whole issue has been a huge conundrum in all of our diagnostic work. So the viral loads, I'll skip this for the sake of time. We did ask about masks and behaviors. Those did not seem to be associated. We asked about mental health, and importantly, during 14 days of quarantine, average mental health scores declined by quite a bit. And when we asked people how hard they found it, if you look at just the overall, about 30% of people found it difficult or very difficult to put up with quarantine. Now, these are the people who answered. We're sure there are people who also didn't actually adhere properly to quarantine. So the key insights, just as I'm finishing, is about 1.5% of our travelers tested positive, 1% in September, 2% in October, 2/3 of these detectable on arrival, and about a quarter detectable by day 7. These were related to the expected levels of risk in terms of country of origin. Rates were somewhat above expected levels, somewhat higher in younger travelers and in men. And the issue is whether any of these are what we call not so much false positives, that's a public health term. Really, they're true positives, but from old disease, but don't represent acute disease. And only 1 in 1,000 positive at day 14. We're still exploring because when we call these people, we actually think several of these people acquired it after they arrived and not from travel. So in summary, for clinical testing, nasopharyngeal swabs in MMM are our specimen of choice. We do sputum in hospital when we suspect COVID pneumonia and the NPS is negative. We use highly sensitive PCR. We use high throughput liquid handling robotics for extraction PCR setup. But the one caveat to this whole system is still a certain amount of judgment in interpreting the CT values for the low positives. High CTs are low viral load. And then in our surveillance, we've shown that the oral nasal methodology can be used in both shelter health and international travel, both the utility of the swab, the MMM, and the robotics. And I'd really like to thank a number of people. I won't name them all to allow Dawn to have her time, but a really fantastic effort by many, many people to make this all happen. So I'll turn it over to Dawn.
All right. Okay, so thank you so much for allowing me to come and talk here about our study on saliva testing to capture asymptomatic and pre-symptomatic individuals. So the genesis of the study really came from frustration about Canada's attitude towards testing. If we look at exemplar countries, countries that have done a really great job at reducing the amount of infections and in fact eliminating it in many other countries, we can see that they invest very heavily in testing the population. So here, and keep in mind that this is a log scale you're looking at, I'd like you to compare the testing rates of countries like New Zealand, Singapore, Thailand, Iceland, South Korea to what we're doing in Canada. And these are countries that have committed to finding and tracing every single case and finding their source. And as a consequence, they do a lot more testing than we do. And in fact, we don't have a really good testing strategy that has allowed us to bring sporadic community transmission down below about 20%. And in our worst days, we had 80% of the cases where we couldn't trace where the cases were coming from. Sorry. So one of the issues here is that this virus is very unusual in that it's spread through both asymptomatic, pre-symptomatic, and symptomatic cases. If we do our favorite comparator, which is influenza, it follows the rules that we teach in immunology, which is basically symptomology follows viral load. In influenza, what you see is that people who don't have symptoms have 10 to 100 times less virus than people who do have symptoms. And as a consequence, the spread is generally higher from people who are in that pre-symptomatic or symptomatic stage. Now, SARS-CoV-2 is very unusual because there is no correlation with symptoms and viral load. And this is a study here that was done in a long-term care facility showing these cycle thresholds for the genes and symptomology. And what you can see is that you have asymptomatic people who have reasonably high loads. You have lots of people who are sort of pre-symptomatic, and this pre-symptomatic period can last a long time, who have very high viral loads. And then you see people with sort of the typical symptomology who have a huge range. And of course, one of the other issues is, especially in populations like in long-term care and children, the symptoms don't always follow sort of that checklist we all look through. And so the viral load may also be fairly high in people who have atypical presentation of symptoms. So the debate about how much of SARS-CoV-2 is actually asymptomatic is currently raging. But one of the things that is quite different from influenza is where maybe as many as 20% of some populations may be asymptomatic. The pre-symptomatic phase is fairly short, between 1 and 3 days, and the major time of spread is estimated to be about 24 days before symptoms start. SARS-CoV-2, we have at least 20% of the population is truly asymptomatic, and other people have such mild symptoms that they often mistake them for all the other headaches and fatigue that we feel in our daily life. The pre-symptomatic period is longer for people who will generate symptoms. We estimate about 5 days, but in truth, it can be between 3 and 27 days, especially in unusual populations like long-term care. And so as a consequence, we believe that the majority of transmission from SARS-CoV-2 can happen in this 5-day period, which can be frequently associated with having a high viral load. And so again, this is another large study looking at time 0 being the first day of symptoms and looking at viral load, and then looking at this pre-symptomatic period in this case. And you can see exactly as I just said, there's some people who have extremely high viral loads in the pre-symptomatic period, some have low, but there's really no correlation with viral load between that asymptomatic and pre-symptomatic period. So as a consequence, our best modeling is that 40 to 50% of infections are spread through either this asymptomatic or pre-symptomatic stage. And unfortunately, very unusually, the frequency of asymptomatic or very, very mild infections is much higher in younger people. As a consequence, this is our case rates in Hamilton as of yesterday, and you can see that it's the 20-somethings, 30-somethings who have the highest number of cases. And there's been many, many studies showing that people in sort of their working or school-age lives have the most social contacts and ergo spread the virus the most. So here we've got this powder keg of spread where we've got people not exhibiting symptoms, but having a huge number of social contacts. Our frustration in starting the saliva study came from the fact that the majority of Canada, and there are some provincial differences, but the majority of Canada still only has testing, frequent testing for people with symptoms. And so we've completely ignored this asymptomatic population. And this is particularly problematic in places like long-term care or retirement communities where the young working people are bringing the infections into the home and not having really good frequent screening. This incredible frustration led my colleague and co-PI, Eric Brown, to write an op-ed for the Globe and Mail about how the NBA and American universities were using asymptomatic saliva-based testing to capture these people in this asymptomatic, pre-symptomatic stage, and Canada wasn't implementing this. So after Eric wrote his editorial, he felt that he had some skin in the game, and he really had to get a study testing to see if we could set up a saliva-based testing to keep the people we care so much about, being the researchers in the IIDR, safe. So he said to me, Dawn, do you think we could pull this off? Do you think we could do a feasibility trial for saliva testing? And I said, Eric, we're in the IIDR. We can do anything. And so we began. Eric assembled this incredible team of technical staff who had lots of experience sorry, in PCR-based testing. And so the technical staff got themselves geared up, and we developed a system for collecting saliva in these 50 ml conical tubes, which you see here. We were funded in part by the Juravinsky Family Foundation. That's allowed us to test a lot of the people who work in the IIDR and the MDCL building, as well as community members, also the families of people, because we knew we had to have a wide net to be able to catch infections that might be brought into our workplace. But importantly, we also got some seed funding from the Amica retirement community, where we were able to test their staff, who they knew that were bringing the infections into the retirement communities, but were not being adequately supported by the province to be tested frequently. So this is what the sort of logistics of nasopharyngeal test. I'm sure Marek will correct me, because I'm sure there's multiple improvements that his system has made. But effectively, like as mentioned, you get an nasopharyngeal swab, you collect that swab, you process it. There's an RNA extraction protocol, a PCR protocol. This is the WHO gene sets. Different institutions have different gene sets that they use. And then, as you heard, there's sort of thresholds where we believe the infection is positive or negative. Our test is a little bit different. So you effectively have to drool in a tube after not eating, drinking, or brushing your teeth for an hour. The specimens get to the Brown labs. We have found that we don't need an RNA extraction. Instead, what we do as part of our BSL-2 plus safety protocols, we heat and activate the virus. And this seems to facilitate enough destruction of the virus that we can access the nucleic acids. We do a very similar PCR reaction. We use a slightly different primer set, primarily because this allows us to multiplex the primer set. And as we heard earlier, there is a degree of availability of supplies, and this allowed us to do that. We include a human gene so that we can make sure we're getting a good quality specimen. And then same thing, we have some thresholds where we believe there's an infection. So importantly, our test was really, could we do this? Could we process hundreds of samples in an academic lab? Could we sort of repurpose the Brown labs into doing this PCR? And so with the help of our research coordinators, we've been able to successfully recruit several hundred people, and we're doing a large number of tests every single week now. And I'd like to show you some case studies about how frequent saliva testing works. So in our very first week, we were collecting samples we'd recruited from a local retirement community. We had a participant who had been participating in what at the time was the voluntary recommendation by the province that people who worked in these sorts of jobs should have a nasopharyngeal swab every 14 days. So this person had just had a negative nasopharyngeal swab, but had enrolled into our study because she was interested in keeping herself and the people she worked with safe. So sure enough, she provides us her very first sample, and we get a positive result, which was confirmed the next day at a provincial testing site. This also led to an outbreak being declared, because in retirement communities, one case is sufficient to cause an outbreak. And suddenly recruitment went crazy at that particular site for our study. There's nothing like hearing that one of your coworkers has COVID to increase our enrollment. So we were able to do a pretty intensive screen of a number of employees and residents who were able to consent at the site. No more cases were found. The outbreak was declared over a little while later. And this participant, had she only been doing nasopharyngeal testing, would not have gone for her next test until 2 days after the outbreak had been declared. So had she not, she never developed symptoms, importantly, she was a true asymptomatic, and she would have gone to work completely infected during this period of time. Had she not been in a study like this, nobody would have caught it because she would have been between her 14-day window. So this is an excellent case about how we have to have an increased frequency of testing for people in these high-risk occupations, because 14 days is not going to cut it. I was quite worried at the time that she would show up at the provincial testing site and she would be negative, because this is a graph of basically the false negative rate from nasopharyngeal swabs. And I think, to be honest, from some of the more recent data, I think this is quite a bit lower, but this is what was published at the time. And it basically said, if you get infected on day 0, your chance of having a negative test is actually fairly high until about day 3. And then when the viral load increases, it gets quite low. So I was fairly worried that she must have been within this sort of early stage, because she'd just gone for a swab, that she would show up a negative, but that was not the case. And as we moved through and did more testing, I realized that we shouldn't have been as concerned, because we have a crack team of nucleic acid savants working with us. And so Dirk had done a sensitivity curve for the genes we were looking at, and had found that actually we can detect a fairly low number of viral copies in the saliva. And so our test seems to be fairly sensitive, although we haven't done a head-to-head comparison with some of the other tests we've heard about. So here's a second case where we were able to help reduce the slow spread and transmission in a retirement community. So there was a local community that had a test show positive in January, and had increased surveillance testing through our study. They'd recruited more people. Some of the residents of the home who were able to get consent got involved. Many of the staff got involved. So on February 1st, we found 2 cases. Presumably those had been infected less than 5 days, because these would all be asymptomatic people. There was no chance that anyone would be providing us a sample when they were symptomatic. Those 2 people were obviously able to be brought out of the workforce because they'd got their results back on February 1st. On February 4th, there was an additional case. Presumably there could have been a link there, because that would definitely be within the presumed infection period. Another one on the 8th who may have been in contact with a person in 4. Unfortunately, by this time, a number of the residents who were not in our study had become infected. So during this period here, there was a high number of cases within the residents, the community, and the last staff member who have identified positive was done on the 16th. So this is another example of how this sort of mass testing, many of these people would have been missed by what they were doing as sort of the provincial recommendations for testing during this time, and has helped them redeploy and get some of the workforce into isolation much quicker than had they not been a part of our study. So one of the things that we get asked a lot is, what about scaling up this? Could we make saliva testing more of a regional test? And I want you to look at the incredible technique that Sarah is demonstrating here with that left-handed opening of the tubes and closing them. Brilliant. Our issue right now is that the tubes are too big. So the tubes are too big to fill in most automated systems. And so this is actually not a trivial issue because what it requires is people like Sarah to do this work manually. But once, of course, we've got our tubes pipetted, we can use these robotics handlers. And through a generous donation from the Boris Family Foundation, we've been able to increase the scale. And in 2 weeks' time, we'll actually be expanding the study to include 2,000 long-term care residents, providing 2 samples a week. So it's scalable, but to a degree that becomes challenging due to the size of the tubes that we use. We also get a lot of questions about quality. There's this mythology that saliva is difficult to use. And in fact, Drew, our master of saliva, reports that 85% of the samples are incredibly easy. Occasionally people have brush their teeth or have some food. And as a consequence, we sometimes see that there are some precipitants in there. This does affect the quality of our results, which I'll tell you about in a second. Some people don't provide enough sample, but a very low number of people, or they evaporate because they don't put the lids on their tube well. And it really is a drool, not a spit. So we don't want the mucus, like we want the clear liquid part of the saliva. But overall, it's not been a huge obstacle. We've also not seen age differences. Many of the people who've consented to our study are quite a bit older and have not reported issues in providing a saliva sample. Intriguingly, we have observed what I showed you in those earlier slides. There's an incredible range in the degree of expression of these genes in these asymptomatic people. So we have some people that are either very, very early in their infection or conceivably late, although we think early. And then some people who have fairly high viral loads. To date, we had one indeterminate test. Luckily, that person was local. We could get a second sample from them that afternoon. They confessed that they had indeed brushed their teeth and then drooled into the tube right after. So that's a big no-no. We think we may have had a false negative, although we're not 100% sure. We've had 14 positives that have gone on to be confirmed at provincial testing sites. And we hope to get a better sense of the accuracy by doing antibody levels to see if anyone seroconverted over the course of our study that we wouldn't have been able to detect. Another major question we've asked is, how acceptable is this? Do you think this is a good idea? And you know, this bar chart really doesn't tell the full story. The stories that we've heard about this testing, we've heard stories from teachers in our study who had students in their classroom and were unable to go and get a test because they were told by the powers that be that until they had symptoms that wasn't required. We've had service industry people who've been so worried that they've been unable to work effectively or to spend time with their family because they've been so worried about their infections. And we've had our partners at Amica speak to us about how important testing is for them to be able to socialize, enjoy life, to feel safe, and to do the things that they need to keep themselves healthy, like be active, join the gym at the Amica community. And so the gratification that we've got from this study is that we've really been able to help our community, both in the MDCL building, but more locally, to help fight these spread of infection due to these asymptomatic or pre-symptomatic infections. I've talked really quickly because I really wanted to make sure we had time to answer some questions, but I just really have to acknowledge the incredible hardworking team that Eric has been able to put together. These people have spent so much of their time and have been so committed to this project. All those tests always have a verification step, and we've had them staying up late at night hoping to get people the best quality answer to whether or not they might have had a positive sample. And I'm so appreciative, and it's been an honor to work with them. I am also very, very grateful for the Juravinsky Family Foundation, which gave us the seed money, the Amica Senior Lifestyles community, with whom we've had the pleasure to work with, the Boris Family Foundation for allowing us to increase our infrastructure, and of course the IIDR for their continuing support. Happy to answer any questions now, or you can contact me through Twitter or email. Thank you so much.
Great, thank you both. That was really awesome. And exciting to see that we are able to catch these asymptomatic and pre-symptomatic people, because you know, this, I think that is one of the scariest things about this whole situation, is that people are walking around completely unaware that they're infected. Okay, so we're going to go to the questions now. The first question is from Mike Surratt. Do we know anything about domestic travelers? So Marek, you want to speak to that?
Sure, I actually just typed a quick answer. So if you're going north, like if you're going to Nunavut, you have quarantine plus testing in Winnipeg or elsewhere before you go. But for the most part, there has not been testing for domestic travel. But it's an excellent question whether, especially when there are parts of the country like the northern, the territories and the Atlantic provinces that have much lower rates. What they've done instead in the Atlantic provinces is you have to do 14 days of quarantine. So if you'd fly to Halifax, you have to be in quarantine. I don't think they test yet, but that would be a logical thing, especially since Ontario and Quebec have much higher rates than Atlantic provinces do. The other future thing, of course, is we might have VOC, so the variants of concern might be different in different parts of the country, and that may up the ante to make sure those don't mix.
Thank you. The second question is from Deb Sloboda. She says, amazing talks. Thanks for keeping our community safe. At what temperature do you heat and activate the virus?
I believe it's at 95 degrees for 15 minutes, but I might have to ask if Dirk or Drew or Sarah or Nikita are there to clarify that. It's consistent with our BSL-2 plus inactivation.
And just wanted to point out why David developed the molecular medium in part because you don't need to heat and activate. And we think that the heat and activation decreases sensitivity. And Mike Surratt thinks that heat and activation may decrease the quality when you're doing whole genome sequencing. So need to better understand what are the safest ways, but also which ones actually give you a really good quality product, especially if you want to do whole genome sequencing.
Mm-hmm. I think that it's a consideration also for the sewage testing that's being done as well, right? So you want to keep the technologists who are doing the testing safe when they're opening potentially aerosolizing samples. There is a question in the chat. Does this data support new mandatory hotel traveler quarantine measures? Marek, I think that was for you.
Yeah, I think I answered that as well. So, so I said, on the one hand, yes, this is a high percentage. Like 1% in September was at least 10 times higher than the general population. Although, the 3% or whatever they saw by January is probably not much higher than in many parts of Toronto and Peel. So it identifies a high risk group that you either need to enforce quarantine or you need to test. And I still believe, though, that in almost all cases, a day 7 testing would allow 7 days of quarantine plus test and then getting people out. That is endorsed by the Centers for Disease Control. Variants of that has been done by other countries. So I think, yes, travelers are higher risk. Yes, they should be in some sort of quarantine plus or minus testing, but my preference is shorter quarantine plus robust testing. I think that would be the best way forward.
Okay, in answer to Deb's question about how long you should heat and activate, there's a multiple chime-ins that it's 95 for 30 minutes. Okay, a question from Dr. Fulford. Do you think there will be any reason to worry about things like travelers once those vulnerable to severe disease have been vaccinated? Because of course, the fact that many people are asymptomatic points out how very mild this virus is in so many people.
Yeah, it's only mild at an individual level. At a population level, just like flu is mild, but hundreds of kids die of flu every year in the United States. In the same way chickenpox is mild, but kids were dying of chickenpox. People, including children, but especially young adults, will still die of this if millions are infected. So I think job one is definitely to vaccinate those at risk of ending up in hospital, and we're starting to do that, and hopefully our risk of hospitalization and death is going to go down dramatically with vaccination of those groups. In fact, nursing home outbreaks are already down, but I don't think we're going to want millions of infections every year in Canada going forward. So I think we're going to really have to struggle once this becomes a milder and milder disease because of widespread vaccination. What interventions are we willing to make? And that's why we did ask that question, would people tolerate vaccination for travel? If you travel to many countries of the world, you need yellow fever vaccination. You need cholera vaccination, which has always been a useless vaccine anyway. So, there are precedents like smallpox and yellow fever for vaccination for international travel. I actually think we need to have that debate.
I think that's a great question because, this is not going away anytime soon. And it's a little bit like Russian roulette. You can have a mild case, but we don't know enough about the long-term consequences of this virus. Okay, Deb has another question. Are either of these testing or surveillance measures something that we could employ on our own campus in the long term as we come back to classes? Should MAC be using this?
Yes.
Yes.
Excellent.
So yeah, and there's a group organized by the vice provost to look exactly at this, and many of us on this rounds are part of that attempt to what can we do for September to allow some level of reopening of campus, which we all would support.
Mm-hmm. I guess the question is the question who pays for this?
Well, yeah, I mean, I'm not very good with money, so I think I'm supportive of testing, and I think we must. But, I think one of the things that's so important too is the 20-something people, the people who work in our labs and work on our campus, are major vectors of spread, even if they don't have severe disease because of all their social contacts and things like that. So I cannot imagine opening a campus and being part of our local community without providing this sort of testing to make sure that we're not part of the problem. I just think that would be unconscionable. And we're starting to see now that even mild infections can have long-term consequences to health. So again, I think it behooves us, if we want to ever have a campus that looked like it used to have these sorts of testing procedures in place.
Mm-hmm. So we're getting a little bit short of time, but there's a couple more questions that we can try to get to. Have you started to look at antibodies in the saliva? And if so, can you share your experience?
Yeah, so it's not quite as easy as blood. Blood is, such a wonderful matrix for looking in antibodies in. The saliva, we're working on, there's been a number of published protocols that we're working on now, and I'm happy with the progress we're making. I'm not 100% sure it's definitive. One of the nice things too is we're doing developing tests so that we can look at both vaccination and infection. So some of the antigens that are only in the infection and some that are in the vaccination. So we'll be able to disentangle those two types of antigens.
And I would strongly endorse giving millions of dollars to Dawn to do saliva-based studies. I think like antibody studies. The PCR part we can debate. I think we need lots of different things, but I think being able to do seroprevalence through an oral swab is just such an easy thing, and we've done it for other antibodies. So I think if anyone's got $1 million for Dawn, please give it to her. It's a good thing to support.
I endorse this message. So the last question is, I'm interested in how the SPIT study could be rolled out to schools. Do you think this would be feasible?
We just got permission to get kids in. And so we've just started. Children of our participants have been enrolled. And I mean, certainly it's not hard to get a child to spit in a tube, in my experience. I think, with really young children, maybe getting the volume might be a challenge. We'll have to see, but certainly I think we need to have more asymptomatic testing. So many people have said, even my esteemed colleagues in infectious disease, it's not so serious in kids, so it's going to be fine. But it's the bringing it home, and especially in the context of these variants of concern, the schools look like they could really be vectors of mass spread. And so I think we must have asymptomatic testing.
I mean, Mark Loeb showed you can do parental collected or self-collected with mid and mid-turbinates. So I think whether it's nasal, oral, saliva, some variant of that. The one caveat is I don't think we fully understand why there's shedding of a lot of virus in many, but not all people in the saliva. One theory is it could be inflamed gingiva. And there's one group in the States that looked at periodontal pockets and showed 1,000-fold concentration of virus there. And we know that inflamed gingiva does express ACE receptors. So the question is, would that work as well as a diagnostic in kids who do not have gingival, periodontal and gingival disease? I don't know. I think we've never thought of the mouth as an important compartment for respiratory viruses. And I think some good basic science of where it's coming from. We know the major risk factors for bad disease are things like obesity, older age, diabetes. Those are all important risk factors for periodontal disease. And I actually believe the periodontal saliva infectivity thing needs to be explored, because that could argue it would work better in adults than in children.
That's actually good information also for dentists who are trying to keep themselves safe, right? Because they tend to see people with the worst periodontal disease. All right, well, thank you both again for this fascinating seminar. I'm happy that you're fighting the good fight for us. And we recorded this session, so if anybody wasn't able to make it, they'll be able to watch it later. So thanks again and have a great day.